Hi, today's topic is thyroid storm. Though it's not a very common condition, but one should know about this condition. For example, this case 28 years old female, gestational age 32 weeks. She is a gravida 2, para 1. Medical history hyperthyroidism treated with methimazole 10 milligram twice a day before pregnancy. Obstetric history, uncomplicated vaginal delivery at term in first pregnancy, no history of preterm labor, miscarriage, or stillbirths. Now she complains with at this time fever, sweating, palpitation, shortness of breath. And the patient presents with 3 days history. Now, with all this palpitation, sweating, shortness of breath, she reports feeling of anxious and restlessness and with increased irritability and insomnia. And she also reports a loss of appetite and weight loss. Now, on examining clinically the vital signs, temperature 38.5, pulse rate more than 100, this is 120 beats per minute, blood pressure normal 170, respiratory rate is also within normal limit, that's 18 breaths per minute, oxygen saturation 98% on room air. General appearance, the patient appears anxious, agitated, with a tremor in her hands. Cardiovascular system, tachycardia with regular rhythm, no murmurs, rubs or gallops detected. Respiratory system, the lungs fields are clear to the auscultation. With all these clinical signs of all temperature rise and all, also the gastrointestinal system, the abdomen was soft, non-tender, no hepatomegaly. Neurological symptoms, system, no focal neurological deficit noted. Now, investigations being done, thyroid function test, TSH less than 0.01 and normal range is basically 0.27 to 4.2. Free T4 more than 50 pmol and normal range is 10 to 20 and complete blood count normal. ECG, sinus tachycardia with a heart rate of 120 beats per minute. No ST change or arrhythmias detected. Chest X-ray normal. Diagnosis based on the clinical presentation and the laboratory investigation, patient is diagnosed with a storm hypothyroidism in pregnancy. Now, how to manage? The patient is admitted to the hospital and managed with the following measures. 1. Methimazole is discontinued due to the risk of fetal hypothyroidism. Propylthiouracil 200 milligram orally every 6 hours is initiated, as it is safer in pregnancy and can be used in third trimester. Propranolol 40 milligram orally every 6 hours is initiated to control the tachycardia and other symptoms. The patient is kept under the close monitoring and any signs of fetal distress or preterm labor. Consultation with the endocrinologist and obstetrician is obtained to further management. Now, this case outcome, the patient's symptoms gradually improve, her vital signs stabilize, thyroid function tests show improvement, TSH increasing to 0.1, free testosterone 4 decreasing to 30 pmol. The patient remains under close observation, discharged home with close follow-up, and she was advised to continue PTU until the delivery and to plan for elective delivery at term. And regenerate response is also there. Now, what is thyroid storm and what is thyroid toxic crisis? It's a medical emergency characterized by severe acute exacerbation of signs and symptoms of hyperthyroidism. It's a rare complication occurring approximately 1% of the pregnant patients with the hyperthyroidism, associated with a significant maternal and perinatal mortality and morbidity, and vast majority of the women presenting with thyroid storm have a history of hyperthyroidism. Hyperthyroidism refers to the clinical state resulting from an excess production of the exposure of thyroid hormones. The most common cause is Graves' disease. It accounts 95% of all cases of hyperthyroidism in pregnancy. It's caused by circulating TSH, autoantibodies. Then ophthalmopathy, there's an axonal loss, lid lag, lid retraction is there. Dermopathy, there's a peritibial edema and clinical signs that are specific to the Graves' disease. Now, other causes of hyperthyroidism in pregnancy is toxic multinodular goiter. They can be inflammation, thyroiditis, solitary toxic thyroid nodule, hyperemesis gravidarum can lead into the hyperthyroidism in pregnancy and storm, gestational trophoblastic neoplasia, ingestion of exogenous thyroid hormones, and TSH secreting pituitary adenoma. In order to minimize the complications, including thyroid storm, hyperthyroidism is best diagnosed and treated prior to pregnancy. An inciting event such as infection, hypoglycemia, diabetic ketoacidosis, venous thromboembolism, surgery, and labor and delivery can be identified in many instances of thyroid storm. Now, thyroid storm is diagnosed by the combination of symptoms and signs with the patients of thyrotoxicosis, and that includes tachycardia, that's out of proportion to the fever, more than 140 to 160 beats. There is a fever. Sometimes there is an altered mental status such as restlessness, nervousness, confusions, and seizures, diarrhea, vomiting, and cardiac arrhythmias. Sometimes diagnosis is very difficult to make clinically. In thyroid storm, it is suspected serum thyroid function should be sent immediately. Biochemical findings supportive of diagnosis include suppressed level of thyroid binding globulin, then increased free levothyroxine T4 and increased L-triodithyroxine, that is T3, is also increased. So increased T3 and T4 and suppressed level of thyroid binding globulin. Although most women with a Graves' disease will have a circulating anti-TSH receptor, antimicrosomal antibodies, antithyroid peroxidase autoantibodies. The measurement of such antibodies is neither required and nor recommended to establish the diagnosis. Moreover, the antibodies levels do not correlated well either the maternal or the perinatal outcome. Now, the differential diagnosis between the thyrotoxic storm can be done, and there are many conditions that can mimic the symptoms of hyperthyroidism and result into the similar clinical presentation. These include sepsis, acute myocardial infarction, pulmonary embolism, and hypertensive crisis. Sepsis, patient will have the fever, tachycardia, altered mental status, which is also common symptoms of the thyroid storm. Acute myocardial infarction, can be present with chest pain, dyspnea, tachycardia, and mistaken for the thyroid storm. Pulmonary embolism can be represented with tachycardia, dyspnea, chest pain, and common with the symptoms of thyroid storm. Sometimes the hypertensive crisis, patient present with headache, nausea, vomiting, altered mental status that can also mimic the symptoms of thyroid storm. Sometimes this is differential diagnosis difficult with the drug toxicity, adrenal crisis, and psychiatric disorders. Drug toxicity can occur with salicylate that can present fever, tachycardia, and mental status altered, which can be mistaken. Then adrenal crisis that can present with the abdominal pain, nausea, vomiting, altered mental status, and can mimic the symptoms of thyroid storm. Psychiatric disorders, they can be anxiety, panic attacks. Patient can come with the symptoms of tachycardia, palpitation, sweating, which can be mistaken for the hyperthyroidism. So the diagnosis of thyroid storm requires a clinical evaluation, proper laboratory investigations, and other relevant tests to rule out the potential causes and the regenerate response. Now, what should be the goal for the treatment of the thyroid storm are to reduce the synthesis and release of hormones from the thyroid gland. So we can use 3 drugs. They're thiamides, supplemental iodide, and glucocorticoids. Thiamides such as propylthiouracil, that is PTU, or methimazole. Methimazole during pregnancy is teratogenic, so it is not given. So most commonly, the PTU, that's a propylthiouracil, is given. The block of peripheral action of thyroid using glucocorticoids, PTU, and a beta blockers. Now, the goals also to treat the complication, support the physiologic function, manage and patient in the ICU setting. Acetaminophen should be given. Cooling blankets are sometimes necessary. Supplement of oxygen, fluid, and chloride replacement. And identify and treat the precipitating events such as hypoglycemia, thromboembolic events, and a diabetic ketoacidosis is important. So, as we acute the maternal illness, fetal well-being should be appropriately evaluated and consideration given to the delivery if necessary. Fetal tachycardia is also a sensitive index for the fetal hyperthyroidism. Only 1 to 5% of the neonates born with a poorly controlled thyrotoxicosis will develop the transient hyperthyroidism or a neonatal Graves' disease caused by the transplacental passage of the maternal antithyroid antibodies. So we should be careful about it. Now, once the patient is stable, which is very, very important, follow the serum electrolytes, arterial blood gas, 2 to 4 hourly as indicated. Catheterize the patient if they're unconscious and not passing urine. Decompress the stomach if unconscious and to continue the fetal surveillance. For women who fail to respond the initial medical therapy, options are limited. Radioactive iodine 1311 is administration to able to thyroid gland is absolutely contraindicated in pregnancy because it will permanently damage the fetal thyroid. Surgery is best avoided but may be required. As known as a thyrotoxic crisis is a medical emergency that requires immediate attention. Here are some general guidelines to treat thyroid storm. Supportive care. Thyroid storm can cause significant stress on the body. Supportive care is necessary to stabilize the patient's vital signs. They include oxygen therapy, intravenous fluids, and electrolyte replacements. Antithyroid medication, first line of the treatment in a thyroid storm is antithyroid medication such as propyl thiouracil, that is PTU, or methimazole. Methimazole block the production of thyroid hormone and help to control the hyperthyroidism. And PTU is preferred that a thyroid storm due to its additional effect of inhibiting the peripheral conversion of 2,4 to T3. The beta blockers are used to control the symptoms of hyperthyroidism such as tachycardia, palpitation, and tremors. Propranolol is preferred agent due to the additional effect of inhibiting peripheral conversion of T4 to T3. Now, the treatment glucocorticoids, in some cases, glucocorticoid may be used to reduce the thyroid hormone production and release. They also help to suppress the autoimmune response of Graves' disease. Dexamethasone is a preferred agent due to its lower mineralocorticoid effect. Cooling measures, high fever is common symptom. Thyroid storm cooling measures such as ice packs, cooling blankets, fan may be used to reduce the body temperature. Now, management of the complication, thyroid storm can cause significant complication such as arrhythmias, heart failure, hepatic dysfunction, and these complications need to be managed appropriately. Patient may require intensive care support. Definitive treatment, once the patient is stable, definitive treatment such as surgery or radioactive therapy may be considered to address the underlying thyroid disorders. Treatment of thyroid storm requires multidisciplinary approach, endocrinologists, critical care specialists, and other healthcare professionals. Goal is to control hyperthyroidism, manage complication, prevent long-term adverse outcome, and this is basically the algorithm which will make us understand what is it, confirm the diagnosis, identify the women at risk of developing thyroid storm, perform a detailed history and physical examination, check for the thyroid function test. Unable to confirm the diagnosis, consider other diagnosis, confirm gestational age, document fetal well-being, and manage as outpatient continued strict control of hyperthyroidism. If storm is concerned, admit hospital immediately, confirm gestational age, document well-being, exclude infection as a cause of thyroid storm, consider checking blood culture, urine culture, and X-ray chest, institute treatment immediately, manage ICU setting, within the 15-minute metrovital signs check, EKG, face mask oxygenation, supplementation up 4 to 6 liters per minute. Continuous fetal monitoring if the fetus is more than 24 weeks of gestation. Now initiate the anti-thyroid drug therapy, propyl thiouracil P2U 600 to 800 milligram orally stat, then 150 to 200 milligram every 4 to 6 hours. If oral administration is not possible, use methimazole rectal suppositories. Starting 1 to 2 hours after the P2U, administer saturated solution of patient potassium iodide, 2 to 5 drops orally every 8 hours. Alternative source of iodine may include sodium iodide or Lugol solution or lithium carbonate should be given. Dexamethasone 2 mg IV or intravascular every 6 hours for 4 doses. Propranolol 20 to 80 mg orally every 4 to 6 hours, and then 1 to 2 mg IV every 5 minutes for total 6 mg. Then 1 to 10 mg in every 4 hours. If patient has a history of severe bronchospasm, consider Respirine and or guanthidine or diltiazem should be used. Then the phenobarbital 30 to 60 mg orally every 6 to 8 hours as needed for the extreme restlessness. Once the patient is stable, continue it, and close observation is important. Thank you so much for the patient listening. Thyroid storm is once in a while. It's a very uncommon and unusual condition, but we should always able to diagnose and to make the differential diagnosis possible. Thank you so much.